Hello and welcome to this section about pressure ulcer and pressure prevention and management. This is quite a large module. It's done over two sections. So you've got online materials to virtual learning environment staff, and there's lots of policies and procedures and nice guidelines. But hopefully this presentation gives you enough of an overview. So the aims of today is to understand how pressure ulcers can develop and what can be done to prevent them. An understanding about the education and support that can be done to provide to patients to help them manage their own risks of pressure sores, so that's psychoeducation, and an understanding for every trained nurse professional's responsibility in relation to prevention and management of pressure ulcers. So pressure ulcers definition: a pressure ulcer is a localized injury to the skin and or underlying tissue, usually over a bony prominence area as a result of pressure or pressures in combination with shearing or friction. So in other words, if we're sitting down for a long period of time, the force against where we're sitting and what we're sitting against causes pressure. And or if we're going to be sheared, so dragged, it can cause pressure. So the main causes of pressure ulcers is a load of force extended on a unit of an area. This is normally the body's weight pushing down on the hips or the sacrum area of the coccyx. It's caused by local capillaries occlusions, so the reduction of blood supply, and it compresses the tissue between the skin and the surface of the bone. This can then damage and often cause under the skin, but not become obvious until the skin above has broken down. Shearing is where there is a pushing or pulling on the skin. This means more than one layer of the skin slides against the other, and this causes damage to the layers, or they may become detached. So we've just done that in our previous module from another or altogether. So you've got pressure pushing down on the capillaries, causing that reduction of blood supply, or shearing, that sliding motion, which again can remove tissue altogether. Friction is where two surfaces are rubbed together. So this could be the skin and the bed sheet, or a chair and a cushion, or poorly fitted clothing and manual handling aids. Hoists are more likely to damage from friction and support the unhealthy skin. Poor manual handling techniques can result in the patient experiencing all of the forms of pressures if the area is damaged. So this is a friction lesion. So again, it's kind of that friction, abrasions that we used to see. So the skin at this point hasn't broken down, but again, we're all very used to common blisters. So if we look at NICE guidelines, so what's the clinical based evidence for this? It says health professionals are expected to take fully into account and exercise their clinical judgment. So NICE guidelines do not override individual responsibilities for health professionals to make decisions that are appropriate to meet the needs of an individual patient. And that's because there are simply too many sliding factors. So hints and tips on grading. A pressure ulcer is an ulcer related to some form of pressure and should not be confused with ulcers related to disease, such as cancer, vascular flows, or edemas, or anything along those lines, or diabetes. You should be able to see the cause and effect relating to pressure within ulcers. So the redness, discoloration all over the bony areas, or related to sitting or lying, or redness or discoloration on skin related to the pressure from the device, such as braces or wheelchairs. So pressure ulcers, so pressure comes from the bony prominence of the body and stops the capillary flow into the tissue. So if we think about that cross section of skin that we've seen on several slides now, it deprives the tissue of oxygen and nutrients, causing the cells to die. Pressure greater than the capillary closing or pressure expected by the bony prominence also disrupts the blood flow. So the most common sites are the sacrum, the tailbone, so our coccyx is the most common site. Semi-flow positions such as slouching in the bed or chair, high risks in tube feeds or incontinence patients, because again, maybe the lack of mobility. Here we've got moisture lesions and other things causing problems. Heels is the second most problem area. So that's the lower limbs, so the back of the legs and leg tracts, and obviously higher risks of PVDs and diabetes. So again, thinking about other areas there. Other bony prominence areas is your hip bones lying on the side, high risks for residents there, ulcers on the lateral foot rather than the heel, or sitting on the exact bone. So wherever you're sitting can obviously raise the risk there as well. So what we're thinking is, if we lay the body flat, any part of the body that's in direct pressure to a surface is at risk of breaking down. So what can we do for pressure ulcers and other sources of pressure? So boots and straps, plaster casts, heels, oxygen tubing, stockings, compressions and bandages, and any device that can lead to pressure directly on the skin. So we would normally use an assessment tool to identify the risk of somebody at risk of pressure sores, commonly known as the Waterlow pressure scale. Here we look at the body weight, so we do the body weight versus the height, the skin type, the sex and age, the muscle, continence, mobility, and again, that all comes together with an overall score, and that score gives you an idea whether they're at risk or high at risk or very high at risk. So the Waterlow scoring points has its problems. So the higher the score, the bigger the risk. The brand, there is another one called the Brandon scale as well. And again, we're looking around the capacity and acceptance of the patient. Waterlow reassessment following admissions, a documented reassessment should occur if you've got a transfer between wards or homes, or if you're in a care home from floor to floor. In between periodic print, in between time frames, so there may be a 4-week review or a 6-week review. Any change in the patient's condition, which is likely to affect, so again, could be deterioration, could be oxygen levels depleting, could be nutrition levels depleting, or otherwise they should be done weekly. And remember to score on discharge. So at the grading scale, grade 1, we're looking at non-blanching, and we're looking that the skin's intact. It's just discolorated, it's gone a bit edema, a bit swollen, maybe red, a bit hardness, and maybe a bit darker in the skin. So a bit of blanching may come around. Grade 2 is that partial thickness, so that's skin loss involving the epidermis and dermis, so that top layer, and the ulcer is superficial or present. Grade 3 goes to full thickness, looking at skin loss involving damage or necrotic or subcutaneous tissue, so that's where it starts to go black and really bad. And grade 4, it's extensive tissue, necrotic, damage to muscle, bone, and supportive structure. So with or without that full thickness and skin loss. So at stage 1, the non-blanching stage, so when it's a reddened area, we also need to assess that and look at any risk reductions at that point. Stage 2, you can see the skin starts to break down. Stage 3, it opens up to subcutaneous and involvements in those cavities are starting to appear. And then 4, it goes to deep tissue involvement. So we never really want to go there. So grading issues, where we have the sloughing and that necrotic part, any pressure ulcer which has the blackened area or the slough where you cannot assess the depth has to be graded at a grade 4. So again, we can move deep, we can move a section up, but that's because we can't see what's going on deeper down. Blisters obstruct the base of the wound, so the deep roots, and therefore we need to treat a wound as a grade according to the state of the wound bed. If in doubt, peer review, get 2 nurses to countersign and review that. And also, visible or verbal descriptions in documents and photographs are necessary as part of NICE guidance. So, pressure ulcers versus moisture lesions. So again, lots of confusion here in the industry to newly qualified people or people that aren't used to seeing them. So pressure ulcers are caused by pressure or shearing. Moisture lesions are caused by pressure. Location, wherever it's the bony prominent part to an area. With moisture lesion, less likely to be over it, it's more to a location where there's a bit more moisture, so incontinence, double incontinence. Shape and edges, usually distinct, edging and shaping, usually diffuse. So again, for this, it's normally a bit all over. Depth, pressure ulcers can be superficial and deep. Moisture lesions are rarely more than superficial. So moisture lesions will always just remain that kind of ready kind of top layer. Necrotic, so the necrosis may be present with a moisture lesion that's not normally apparent. So the assessment for pressure ulcers looks at cause, site, size, stage, cause, and all of that lot, appearance, sloughing, pain, wound, and all of that lot. Obviously, just support it with a photograph. If you support it with a photograph, you're done. Then obviously that tracking and tracing of the wound, so the size, depth, and all of that lot. Pressure ulcers are required to be documented, and again, you need to grade that because it could result in a safeguarding inquiry. So, the competency framework looks at the fact that we need to be able to assess those and then obviously reduce the risk. So if people are laying on the back, we've got the back of the head, shoulders, elbows, buttocks and heels. If the patient is laying on the side, we've got ears, shoulders, elbow, hips, thighs, legs and heels. And if they're in the prone position, face down, we've got elbows, rib cage, thighs, knees and toes. As you can see, it's the tissue damage will happen to more in the bony prominence areas. So this is where the tissue is in direct contact with another force. Also thinking about if they're laying on the side or in a wheelchair. So if they're laying on the side, you've got the ankle on the other ankle, the knee touching the bed, the hand, the shoulder, and again, we're just thinking all over of where these pressure sites could be. So you can see patients could be at risk even in a sitting position. We cannot afford to forget patients that are sitting out, they're still at risk, and even though they may be mobile. So again, we need to make sure that we encourage that regular movement and stimulation all the time. So pressure areas in a wheelchair is your backs, your lower back, your hips, the sacrum area, the back of the legs, and the base of your feet. Medical devices and equipment can obviously cause pressure sores, so anything that's on the body for a long period of time can cause pressure ulcers as well. So it says here, NICE guidelines says we recommend the following in terms of pressure ulcer prevention. Assessment of the patient's risk of pressure, injury within 6 hours of admission to hospital for each episode of care, and regularly therefore depend upon the severity of the issues identified. So assessment 1, we're going to be looking at basic factors around mobility, sensory, neuropathic, dementia and levels of cognitive, the levels of illness and whether or not they're conscious or not conscious. We're also going to look at their age, if they've got vascular disease, because circulatory problems could be a problem, chronic issues, previous history of pressure damage, and problems of malnutrition and or dehydration. Factor 2 looks at pressure, shearing and friction, and other medications. So other factors could be medication and moisture to the skin. So therefore, using the body map in the generic assessment documents, it's good to record if there's already skin damage, because if skin is already damaged, if there's already contusions and bruises and abrasions, they could open up and result into pressure sores quite quickly. Use the daily check charts to record on a daily basis that every area has been checked and that if a pressure ulcer is graded accordingly. Care Plan 2 looks at a patient who is unable to respond themselves must have a repositioning plan. So the plan on every 2-hour repositioning day and night includes a 30-degree tilt on the bed and rest. The repositioning regime needs to minimize prolonged periods on bony prominent areas. We need to minimize friction and the shearing damage, and we need to ensure good manual handling and correct equipment. Finally, we need to specify the position that takes place regularly, even if the pressure relieving devices are in place. We need to establish and maintain a record of those repositioning tasks, and you must record every incident of repositioning. Care Plan 3 looks at a patient with a pressure ulcer which is graded 2 or above. So we've already got that skin being broken down. Any equipment recorded, whether it has been already obtained or whether it has been requested, when and by whom. Dates and times should be sent for evaluation of pressure ulcers, and wound care plans need to be sorted out. Pressure reducing mattresses should be in place and the patient's weight more evenly across the surface of the mattress. Pressure relieving mattresses such as alternating mattresses are designed to completely remove the pressure from areas of the patient's skin. Each pressure ulcer should have an individualized care plan detailing the wound care for the general measures to reduce further risk. Ulcers which developed under the EPUAP grade 2 or above, not to be retrograded, they become healing grade at 3, heel ulcers or healing grade 4. So pressure ulcer care plan should detail the area, what measurements are being used to reduce the risk, looking at the requirements of nutrition, continence, pain management and mobility. If a regime of turning patients is in place, there must be a means of documenting each time when this is done and by whom. Care plans should set up a review date and those need to be reviewed. So checking the skin, inspect your skin each morning if it's your responsibility. So patient involvement encourages patients to maintain their own nutrition. So obviously eating more proteins and oils, fruit and veg, bread, potato, cheese, and poultry, and obviously maintaining good fluid intake. Advice regarding skincare 1, so avoid massaging bony parts of the body, because again, that can cause shearing. In bed, your position should change every 2 hours. Bed sheets should have no creases, because creases can cause pressure ulcers. If you cannot move yourself, ask for help. Try to avoid the dropping crumbs or food or debris in bed where you may lay on them. Skincare 2, if you can move around in your chair, try to change position every 15 minutes. Avoid being dragged when you are lifted. Dragging causes friction and increases the risk. Do not use a ring cushion, as these increase rather than reduce pressure. And avoid staying in one position for more than 2 hours and spread your weight evenly. Use warm but not hot water and mild soap to cleanse and use to moisturize to the skin, but dry, and avoid cool or dry air. If you have a problem with incontinence, your skin should be cleansed as soon as possible using soft cloth sponge with a reduced friction. So that's why we use the Pro Shield sprays. Clean your skin at least once daily. or ask a carer for help. A mirror will help to see those hard to reach areas. Advice regarding skin care 4, look out for skin changes, as in the colour, if it goes purple, if it starts to blanch, if it goes dark. Look for swelling, especially over the bony areas, blisters, shiny areas, or dry patches. Cracks or wrinkles in your broken skin, please make sure that you let people know first. So if we're going to get patient involvement, we obviously need to make sure that we've got the Mental Capacity Act done. So the Mental Capacity Act looks at 2 stages, that the person has capacity for their wishes to be respected. And if the person doesn't have capacity, then we follow the best interest. Delegating care under the NMC Code of Practice, it is the registered nurse's responsibility to ensure that if we delegate care duties to non-qualified staff, that they are competent and confident to complete the task set out to the standards that we require. This is of particular relevance in primary care when registered nurses are delegating this care to home carers and patients and relatives. The RCA process is now that the NHS local authority requirements that grade 3 and 4 pressure ulcers, wherever they occur within the trust, are reported as a serious incident, requiring investigations and to be investigated in accordance with the root cause analysis process. References for this, obviously, we can look at the National Institute of Care of Excellence and the Royal College of Nursing. The root cause analysis process, it is now an NHS LA, just done that, sorry. And equally, we've got some websites there for you to have a look at around wound management and looking at those Waterloo scores in more detail. So hopefully, this section has given you, if we go back to it, an understanding of how pressure ulcers develop and what can be done to prevent them. So we're talking about good nutrition, good hydration, good cleansing of the skin and body, good moving and positioning. An understanding of education support that can be done to provide patients the help to manage their own risks. So we told you, that was the last section we just covered. So looking at those abilities to manage and assess their own skin, look at their own things, report them on, but obviously understand competencies. And an understanding of every trained nurse's responsibility, which is if we're going to ask people to look after pressure care, that we're discharging that responsibility properly and that people understand what to look for and what to report. So I hope you found that session useful, and as always, I will see you in the next session.